So it's now my great pleasure to thank Dr. Sani again, but also to welcome Dr. Andy Lee to the podium, who will be leading our plenary session on promising practices in clinical navigation of building systems to meet patient needs. And I think just a couple of words are in order as he makes his way up, which is that he is the Director of Specialty Care at Los Angeles General Medical Center, which is the largest medical center in Los Angeles County Healthcare Network. He completed his residency in internal medicine and fellowship in endocrinology here at USC Medical Center in 2007 when there was a joint collaboration with Los Angeles General, and then remained as a full-time faculty here at Keck. And so he has been at Los Angeles General since 2013, which is just across the street from us. So we're really excited to welcome him and his colleagues here to the podium, and I'll turn it over to him to carry us through. Thank you.
All right. Thank you so much. As you can hear my background, I am an endocrinologist. I do nothing with cancer, so I'm here to tell you everything about cancer, right? So thank you so much for inviting me to this symposium. I just want to get a quick poll just so that we know the audience. This session is really, we want to maximize question and answers. So please get your questions ready. We got a really great panel here. And they're every aspect of our local healthcare system that really promotes equity. So this is the reason I'm here. I'm here to promote them. So can I get just a show of hands? Who are researchers that looks at cost effectiveness, all the statistical analysis, so I can get a sense of the room? Okay. Who are community partners looking to see how they navigate patients? I know we got promoters. Okay. And what about providers, nursing, social work? Anyone that's clinicians? Okay, thanks so much. So if you guys can have some questions. So the way I've designed this session is, let me see what the clicker is. Clicker is this thing? Okay, perfect. Fancy. Okay, all right. So I'm Dr. Andy Lee. I'm the Director of Specialty Care. I'm actually Chief of Endocrinology over at LA General. I'm here on behalf of LA General. LA General is a great academic partner with USC. We're successful because we have great faculty that's also from USC. And I think it's from this academic partnership in a really complex population that we study and we would design effective interventions. And it's a great opportunity for us to really show, I would just say United States, how we can run a county extremely well with the appropriate incentives and actually align the actual outcomes. So for today, let's see, here we go. I think you can see the session. So I just want to start off with in terms of cancer, okay? So if you go into any probably executive meeting talking about cancer care, to be honest, and what I've been, I've been in a lot of meetings with oncologists, surgeons and things, or even just CEOs and CMOs, it's not uncommon, if you can see kind of an executive board, to really talk about cancer delivery, talking about ORs, about infusions, about the cost of providers, right? But we all know that big elephant in the room. Specifically, you're saying, underserved patients, right? So you can have these huge investments in giving them resources to many different things that for clinicians, we're comfortable with. We've done the studies, but we know that elephant's always in a room because when you implement it in real life, patients don't show up, they don't adhere. And then you say, you know what, that's just poverty. We have no way to penetrate that. And that's the difference between Los Angeles County. That elephant in the room can't be an elephant in the room without reckoning with it. And today I get the pleasure of it just describing our context, right? And this will be discussed a little bit more in detail. So the Commission on Cancer actually puts together data and they analyze different cancer sites, right? So this is the data. So our COC and our cancer site actually is sharing this data, and Dr. Ganai can talk a little bit more about this. But as you can see, the green is the percentage of Medicaid population at our facility. You can see how big that is, right? So we're at an 89% in 2021, our facility of Medicaid. And take a look at all the other COCs throughout the United States. So if you're looking at effectiveness, research, everything, that is based on that green sliver, right? How are you going to translate that investment into a Medicaid population? That's the challenge. No studies on that, but we live it every day. So if you're going to sit in the boardroom, you're going to talk about investments, you're going to point to that elephant in the room. How do you design a clinical care plan addressing it? So today, we're going to put together a panel where the elephant is in the room, okay? So we contend with it at LA General. We have academic partners that understand this, and we welcome any one of you to join us. And to do this, I just want to introduce some of my colleagues here that's going to talk about at LA General how we actually design equity into our care plans. And it starts from all the way from the top to people who are working the front lines. So each of them have a few slides just to talk about their scope and how they see themselves actually building equity into the healthcare system and their challenges and some success. So first piece, I'm going to have Erica Braxton. She is our Chief Quality Officer. She has a mission. She has a mission actually at LA General in actually revamping our equity directives. And there's a really great framework, and I wanted to just bring her up and talk about how she's led our equity strategy at LA General. So.
Thank you, Andy. Good morning, everyone. He said I was Chief Quality Officer. I'm actually Chief Equity Engagement Officer. That's fine. I feel like you're trying to protect me. We do still exist out here. We are not all gone, and we are still doing the much needed important work.
So here's one of my famous taglines: diversity is a fact.
Sorry.
Yeah.
As a video, it's okay. That video actually planted some really important seeds for us, not just at LA General, but across the Department of Health Services. So that voice that you heard is in the deck, so I encourage you all to look at it. That's Derica Blackman. How many of y'all have heard of her? She has a really great LinkedIn series around equity. I encourage you all to check it out. I think you can probably get it and watch it for free. But in one of her slides, she says, diversity is a fact. And if you look around this room, it's a fact that we can't deny. If you look at LA General's ED or our inpatient tower waiting room, diversity is a fact, right? She says inclusion is a practice. Inclusion doesn't just happen. We have to be intentional about looking around the room to see who is participating. Oh, you want me to come up? Okay, sorry. Thanks. Inclusion is a practice. Inclusion does not just happen because we want it to. We have to be intentional about looking around the table, who's missing, about talking to our patients and families about what is needed. And then she says, equity is the goal. The goal is equity, and I'm going to talk a little bit more about that in a second, but we used to talk a lot about equality, right? Giving everyone the same thing. We can't do that anymore. The patients that we serve are so diverse. Last year, we served folks from over 120 different languages. So language access becomes a huge issue, right, when you're serving such a diverse population. So equity is the goal. And at DHS, we've added this last one, anti-racism is the outcome, right? Because we work for such large institutions, sometimes barriers are built within our systems, right, within our processes. We have to take the time to actually look at those, question those, and rework those so that anti-racism is truly the goal. Down here at the very bottom is the tagline and what we're really using to educate and train our staff at DHS and at LA General. We are moving away from this concept of cultural competence and towards one of cultural humility. And let me read the definition. Cultural humility is a lifelong process of self-reflection and self-critique that involves continuous learning about different cultures and recognizing one's own bias. So when we're on the front line of providing medical care, it's not only about who we see in front of us, it's about the lens through which we look at those patients, the lens through which we look at our work. There are 5 folks like me across the Department of Health Services, and alone we cannot do this work. So we are using this year as our cornerstone for training for folks coming into our system through our new staff orientation, as well as folks at the very higher levels of our organization through our top training. So just so you know, it's something that is going to be built into the fabric of what we do. Thanks. So remember I said that, equity is the goal. We used to think about equality is in terms of everyone gets the same regardless of if it's needed or right for them. We want to shift that a bit to this concept of equity, right? Everyone gets what they need, understanding the barriers, circumstances, and conditions that make access challenging. So we want to encourage everyone to start to shift their focus, and you will see that in practice as we talk about our cancer navigation program. So, as we get everyone's mindset in the right place, right, and ensure that everyone has this lens through which they approach their work, we do our due diligence by collecting data. We heard a lot about data. Data is so important. That's how we're able to assess and identify where those gaps exist, right? Identifying and reporting disparities in care. Once we have the data, we have to do something with it. Implement solutions that eliminate disparities. You're going to hear us talk about that today with our cancer navigation program, and then evaluate the effectiveness of those solutions. This is a continuous cycle we are encouraging everyone at LA General and DHS to start to go through as they think about how we can reduce disparities. So, thank you.
Okay. All right. Our Chief Equity Officer. So I think it was so incredibly important for our institution to have an investment of a leader like that. And we hear it every single day. We hear it in every one of our projects. And I think it does set the table. And in our executive meeting, she's front and center. She's at the table. So I'm blessed to be in an organization that understands that our mission is aligned with a leader that actually sets the table in that way. So the second thing I want to talk about is, again, nothing related to the investment of providers, ORs, all those genetic testings. It's really about the patients. And most of the time, we don't really understand why patients don't show up. We invest so much money, but then there's a lot of reasons, even when they receive, some dollars. So there's just a lot of barriers. And the unique thing in the way that we approach cancer navigations is we've actually invested in individuals that understand the social lens with much more depth. So I want to invite up Letitia Lair, who's the chief of our social work, to talk about that big elephant in the room that we know exists, that actually alters our outcomes, but we can't really wrap our clinical systems around. So I'd like to invite her up to talk about social determinants and how she's addressing at LA General this particular facet of healthcare.
Thank you, Dr. Lee. Good morning, everybody. I want to start off by saying that this month is Social Work Month, and I cannot be more proud to be sharing my space this very morning. And thank you, Dr. Lee, and the provider team here. And certainly I want to give an acknowledgement to a key supervisor that works with my team that's here in the room that has also led this effort. So it's Social Work Month. The theme is compassion in action. That is a social worker. A bit of trivia. Did you know that the profession came about in the 1920s? LA General had a social work already staffed in 1912. So we were ahead of the game, Dr. Lee. And right? So I don't know if we were calling them social worker, but I want to say, for the purposes of today, that oftentimes in different environments, we call them psychiatric social workers, clinical social workers, medical case workers, substance abuse, community health workers. At our hospital, we use these titles as well, but they all do different things. Half the time, and since I've been a chief, part of the work that we do, because we're a training facility, is to train people on the profession. But this team, at any given time, can provide mental health assessments. We have community workers, different education levels. Let me say that again. We go beyond tokens. We have a profession, we have a master's degrees, we're licensed by the Board of Behavioral Science. This is the kind of team that responds to day-to-day social determinant needs at LA General. Is this forward? Green button, okay. And so having said that, we have about 120 folks across the hospital, and I often get a lot of requests to continue to help because, as you heard in the earlier speaker, the importance of housing, transportation needs, et cetera. We are everywhere. From the minute that person steps on the ground, we have our clinical staff in the ED. We're a 24-hour facility. In our outpatient, our inpatient clinics, we actually also help our people who are incarcerated who come and give babies. So the important piece is that at any given point, my team, the provider puts in a consult and we respond to that consult. Now, it might take us a little bit because there's about 120 of us and we have an entire enterprise across the system of care. We have a community wellness center as well. You'll probably hear a little bit later from Dr. Gonzalez on that, but we are across all the area of the hospital. And that's what makes us, I think, unique and poised to have partnered in this construct of the cancer navigation. On that note, so what makes us so special, right? I believe I'm special, but you all are special. We all have a discipline, providers, medical providers, specialty areas. I think what makes it very, very unique is the augmented lens in which social workers are trained from the very beginning, right? And that is this biopsychosocial that we often read in the literature, but it's very hard to do, as we talked about, right? Understanding the context. When we're working in medical models, right, we also have to understand the emotional well-being of that person. We talked about in the healthcare, people will talk to us about behavioral health. What's that emotional wellness that comes together? And so my team gets to work directly with the providers, understanding the biological cancer needs with that. In addition to that, the emotional need. You're not gonna be able to get a patient to come in if all of a sudden they heard cancer and all of a sudden they're distraught. It might take them weeks and weeks to finally figure out, what do I do next? Right? So it's really important of why, as a social work director and my teams, we also partnered and began to develop a strategic, basically, care team. We are members of the care team. And even today, the mere fact that we're on this panel really is our effort to integrate how we're working together because we are changing a system. I'll say, as I love the enterprise, we work really well, but there are fragmented systems even within our hospital. It's a huge hospital. But the care that we bring together, the cancer navigation team, which you'll hear about, is composed of a supervisor. So we have to also allocate the resources to actually navigate the services, right? A licensed clinical social worker. And then we have 10 medical case workers, all with bachelor's degree. And as part of our profession, what we do is advocate for the patient first and foremost at the center to empower, to help them share their story because they too have a story, right? We provide mental health consultation. We assess at a minimum what might, with standardized tools, what are their emotional needs, and then determine if a licensed practitioner, an LCSW or a clinician should follow up with them and or link them to additional support services. What we also do that's at the center of this program is facilitate between the provider teams as well, right? I mean, even myself, reading what my health plan provides takes quite a bit. Many of our patients are monolingual, different languages, literacy level may be low. So we also educate on health literacy, help them navigate the system, make calls with them. A lot of what we do is follow-up appointment from the beginning that they're diagnosed until they reach surveillance. That's what makes us so unique. The follow-up component from our patient and our social work team is right there from the minute that they actually get referred to our program. So what we were wanting to do continuously is align those resources. And even when they're not available, folks, my team really, sometimes I call them miracle workers because I don't know how they actually get that done, but they stay on the phone and they will help them with the key notion really of navigating our systems internal to our hospital, how to even get to point A to point B, but also external, how to access that transportation, how to go about talking to their health plan so that they get that transportation. A lot of housing insecurities, we talked about food insecurity. Our social work team and the cancer navigation has been working to address some of those barriers in our system. Thank you.
Amazing. Okay, so I'm gonna bring up 3 additional speakers, and I started with Erica Braxton's our Chief Equity Officer, and also our Chief of Social Work, Letitia Lara, because they actually set the strategic ideas of making sure equity and also social work is embedded in every aspect of everything we do. So now I get to bring up 3 award-winning program leads. okay? So you get to see how this works in action. Dr. Soni obviously explains this very complex product of health insurance and incentives. But what happens when you align those incentives and they become actual true outcomes? You get to see that today. So first off, I'm going to talk about why primary is so important. Primary care is so important. Not just primary care, but PCMH, how it is looking in the modern day, just right next door. Happy to study it. You guys, any takers wanting to study how the effect of primary care? This is the contact. So Dr. Manuel Campa, our Director of Primary Care at LA General, please come up.
Morning. Thank you, Dr. Lee. Really honored to be up here with this distinguished panel and to follow Dr. Soni. Really, this is probably more a microcosm of what she's explained. So we'll definitely give a lot of connections to the discussion that we heard at the start. But really, as Dr. Lee mentioned, at the core of DHS, primary care really sets the foundation for how patients access us. But even going above that, right, the way patients link to the medical system in the United States, in California, is by having access to a health plan. And through the different Medi-Cal expansions that Dr. Soni referenced, we've seen our population grow in terms of having access to health plan resourcing. And so Dr. Lee mentioned 88+% of our patients are actually enrolled into a managed care Medi-Cal health plan, which, as Dr. Soni mentioned, bring value-based care. So through capitated payments, our system is able to manage patients and hire multidisciplinary staff, including social workers, providers, nurses, to provide robust care for these patients. And then on top of that, the state and the federal government give incentive funding for participants in public healthcare settings who are taking care of the really big bulk of the state's Medi-Cal population. And so we participate in value-based incentive programs and compete with, well, not necessarily compete with, but we are compared and ranked against institutions such as UCSF and SF General and Alameda Health and Riverside County. And so DHS and LA General, we are working with the state, we're working with the health plans to really drive good quality outcomes that include so many of our cancer screening metrics. So once patients get in, they get assigned a primary care medical home. We have so many services that are integrated within the medical home that provide services across the board for pediatrics and adults. We've worked on food insecurity, really being a core piece of the social determinants, mental health as well. And we've really used this model of Medi-Cal incentive funding, Medi-Cal managed care to generate proactive population-based preventative care. So moving away from the clinic visit, right, one-to-one, I'm really going to take care of you, I'm your PCP, right, here's our care team, but really thinking broadly about equity, right? We know that we have an assigned population to our clinics, to our facility, we know who they are, we know where they live geographically, we know their race, ethnicity, their language. How can we design interventions that touch everybody through the lens of equity? And so I'll share some data. How do I? Green? Okay, sorry. There we go. All right. So we really thought upstream, right? We spent years and years trying to deal with how to manage patients when they came into the clinic, and it works to a degree. You know, you can get people their mammograms, you can pass out fit kits, you can schedule them for colonoscopies, or you can do your pap smears. But really, at the end of the day, you're not going to be able to touch everybody, right? And that's, I think, most primary care clinics know that not everybody's going to get in for all their care and get everything done at once. Dr. Soni mentioned you got to split things up sometimes. So we moved a lot of our interventions upstream and really thought, again, how can we be proactive? How can we use data? How can we use equity lenses to really address the preventative cancer screenings? So just some examples, we used a registry-based proactive scheduling model to identify patients that were overdue, due, and had upcoming mammography, and worked with our radiology partners to get them proactively scheduled with really engaged outreach. And I'll show some data, our rates increased. Same thing with fit kits. There had been early experiments with how we mail fit kits directly to patients, and Administratively, these are a lot of challenges. Funding, right? How do you get a vendor? So we had people stuffing envelopes, volunteers, social workers, nurses, stamping, taking it over to the mailroom, really as an experimental model, and saw how much of a benefit it was when you can use data to identify high-risk populations, get them their kit directly to their home, and then engage them, right? We know that so many patients now are digitally engaged with their healthcare systems through portals, through text messages, and so we were able to build out models that allowed culturally based interventions and language concordant interventions to really engage patients that this was an important screening test. And then what we learned with cervical cancer screening is, I wish I could, well, actually maybe in the future we can send out, collect, HPV collections for cervical cancer screenings. But really we knew at the end of the day, after years and years of trial and error, you have to have access. And so we tried to, in a budget neutral way, extend access strictly for cervical cancer screenings. And we really saw some amazing outcomes with this. And we brought in folks, I know Dr. Gonzalez oversees also our wellness center. We brought in food insecurity, community resources, Metro passing out bus cards, our social work team navigating patients to resourcing, just in these events where we focus strictly on the cervical cancer screening. So here's some data. This is, again, just a microcosm of LA General. We saw in early 2022, when we were recovering from the pandemic, our rates were abysmal. 41% of our patients were in compliance. And again, little by little, we worked on all these interventions, really all those equity pieces that eventually brought us to almost 70%. That's crazy, right? When I saw this, I couldn't believe it. And again, this is a county hospital, and we're getting compared against these UC systems, and we're above the 90th percentile. So we're doing the work. We're doing the work, and the outcomes show it. Colorectal cancer screening as well. We hit a nadir in the recovery phase post-COVID, but little by little, with these different trial and errors, getting fit kits out, engaging patients, we've seen those rates skyrocket as well. We've never had colorectal cancer screening compliance in the 60%. It's so hard to do. And just to reference Dr. Sonia's discussion, through 2022 to 2024, there were multiple phases of Medi-Cal expansion. So our denominator increases year by year. So we're overperforming above what those baselines were. So again, these are just, again, thinking as far upstream and thinking about our patients and how we can do this equitably. And then the same with cervical cancer screening. We skyrocketed these rates. It's so hard to engage patients to come in and get their cervical cancer screenings. We're hoping, more new interventions can drive this rate even farther up. But again, we saw just skyrocketing rates once we were able to bring in, equity into the work. So what we do, primary care, we own it. We own it, and we're going to continue owning it with all of our teams, get those cancer screenings done, early detection, and then, as my colleagues will discuss in more detail, referring to our coordinated and integrated cancer care programs. And so, that's our LA General story.
Thanks, Dr. Campa. If you have primary care questions, please write them down. I'm sure you have plenty. So I want to invite up Dr. Carla Gonzalez. But the reason I picked these three award-winning programs is for any cancer, we know screening's a big thing, right? I think it's clear primary care changes screening trajectory, okay? And it's not just from the visit. A robust PSMH model brings in a very effective strategy to have rapport with patients, enough for them to trust their primary care team to do the screening. And there's no doubt. And primary care is not just a physician, it's an entire care team. It's integrated with behavioral health, social work, nurses, community partners, things like that. They're the incredible hub that established a foundation where the incentives that Dr. Soni talks about will land, and they know how to disperse the funds and hire the right staff. So screening challenges, primary care, that should really be the first question if anyone asks, are you doing screening? Well, is there health insurance? Is it assigned to a primary care physician? Do they have a strategy, right? Second is now you're for a lot of patients, trying to get that diagnosis. I know that was one of the biggest questions that the cancer team really tasked us to really answer. So it's a very challenging thing for two reasons. One is the diagnosis. You can go back and forth, or there are a lot of challenges in developing a healthcare system, in getting patients to a definitive diagnosis. And secondly, a lot of patients, probably the first time they actually even touch a healthcare system, right? Navigating into an uninsured to an insured status. So what better than the director of the urgent care, Dr. Carla Gonzalez, as well as the Wellness Center, to talk about her award-winning program, Cancer Dash. Dr. Carla, and give her a round of applause.
Thank you, Dr. Lee, and thank you all for being here, and thank you all for the work that you all do. We're all doing this together. We really are, and it's such an honor to be here with you. Okay, so I'm going to talk about cancer diagnosis early on. So we talk about a person that maybe comes and already, we have an award-winning program that Leticia touched on with navigators that are helping patients that already carry a diagnosis. We know the cancer. They're going through very difficult times. They wrap around them. We see them through surveillance. But what about, we call it the state of limbo. Patients are coming into our emergency room. Patients are coming into our urgent cares, and they're coming in with the story, I went to an outside hospital, I had a scan, and they told me I have a mass. That's it. That's the story. And then they come in with 2 little pages of a discharge paperwork, nothing else, no other story. And we are here to try to figure out, well, what is this mass? And early on, we figured out that we didn't have the resources that we needed to move as fast as we could. Or actually, we had the resources, but we just had to tap into them in a different way. So we were dealing with an extremely vulnerable limbo state. You don't know what you have. You've only been told you have a mass. You were told to go to LA General because that's where they'll take you. Patients had already been to other health systems and even tried tapping into maybe even their own health system and not been successful. And we know that we wanted to develop something that would not break the system. We would use the resources that we have. We would place them in the right setting. So these patients did not need ER care. They weren't in a need of an emergency care that you would receive in the ER. They didn't even need care in a hospital. What they needed was to figure out how to get to this diagnosis. We also needed it to be patient-centered to deal with all of the patient's diversity and all the things that they bring with them, all the complexities that they bring with them, including our health literacy. So this is where we were when we developed Cancer Dash. The targets of Cancer Dash were making sure that from the time the person presented, not yet maybe having health insurance, a lot of times not having health insurance at all, touching the system for the first time, getting them to the urgent care appointment and transition to their diagnosis within 48 to 72 hours. We wanted to make sure that we understood how to schedule important imaging studies, but I am a family medicine physician, and I have to be very honest with you that I did not have that history. We did not have the history of what is the right imaging modality for this? How do we get to the right image for this study? And sometimes they came with workups. Sometimes they even came with outside biopsies. So how do we get that? They brought in their little 2 pieces of paper, but we didn't have anything of value that we could really go with. So how do we get that information from outside systems? And then we really wanted to target the time that we saw them to the time we had a biopsy done for them. So these were our targets in the Cancer Dash program. So what we did is we created a pathway, an existing pathway using a program called the EDX pathway, where we use our nurses, follow-up of ER, they would place them in an appointment into urgent care so that we would see them within 48 to 72 hours, drastically improve the time that we were able to get a first touch on them. And then the creation of a pathway to get imaging studies. So imaging studies, before all of this, our nurses or the patient had to be on the phone for sometimes 40 minutes to an hour to try to get an image, and an image that I had ordered, and I didn't even know if it was, I was hoping that it was the right image that I had ordered. So we developed another pathway, a pathway using expert schedulers that could look at our lists and really make sure that they got the patient scheduled in a timely fashion. And then training with our providers, because as I mentioned, we didn't know a lot. So I'll tell you a little bit about the pre-tumor board in just a second, but it's really nice that I came to Dr. Lee and I said, Dr. Lee, I don't know how to get to a biopsy in time. I'm not sure what to do. We have to speak to so many different specialists. What can we do? And at that time, Dr. Lee said, we're going to have a pre-tumor board and we're going to put them all in the same room. He had this vision, and I was like, we're going to put in all the experts in the same room, and we're going to have, all the experts. And he said, yes, that's what we're going to do. So every Tuesday morning now, I do have the specialists. I have them for 30 minutes. They're held hostage with me, and I get to ask all the questions. And this is really where the learning has taken place. They have been so incredible. Again, using all of the resources that we already have in teaching us and getting to the right type of biopsy. This is a biopsy that we could do, yes, but this one will be better, and this one will get us to diagnosis faster. And then streamlining the process for getting those outside records, which is pretty much a terrible nightmare to try. If you've ever tried to get outside records, let alone pathology slides from an outside hospital, it can take weeks and weeks to do this. So we really had to work with our health information management to develop certain workflows for this. All of this already existed. We just had to harness it in a different way. So we started our work in March of 2023, and we ended our formal research of it in April 2024. But we were able to decrease by half the time from the first presentation to the urgent care clinic by half. UCC urgent care visit to a relevant imaging by also half, and to the time to a biopsy by half. And that was really where we really wanted to be. Now, I don't have data on what it's like out in the community, because I don't know, when patients present to you guys in this same fashion, I don't know how quickly it gets to a biopsy diagnosis. But this is where I needed to get to in order for Letitia's amazing team to be able to take over and then continue the work that we were doing. And then, of course, specialty appointment, which Dr. Lee has worked so much on, and improving the time that they get into definitive care. So we are very proud that we have the Cancer Diagnosis and Staging Help Award. This is a commitment to serving people and solving problems. Very excited about this. It continues to grow. We're continuing to get better. And honestly, we want to be the gold standard at LA General in getting to where we need to be to get these patients that are in a scared, vulnerable state, as we all would be, very patient-centered, to the right place and the right care. Thank you.
Okay. All right. And again, anyone who's interested in doing partnership and research and what she's doing, she's open to that. Okay. It's already produced outcomes. Okay. All right. So we talked about screening, how important it is to have empanelment primary care healthcare insurance. Secondly, getting to a diagnosis, you really need somebody with, I would say, a lot of empathy in designing systems where you're getting a lot of things that you just naturally wouldn't deal with, to educate the patient to sign up for a health plan and to go through the barriers of actually getting imaging, biopsies, and eventually getting to a diagnosis. Once you have a diagnosis, then it's what's the first treatment? And we do have, this is such a big program where actually it's a pleasure. We have Dr. Raff here, who's the lead of this big DHS cancer navigation program. My focus here today is I really wanted to show you from boots on the ground, individuals that actually are designing very clear care pathways. Dr. Ganai, who's going to talk about treatment challenges once you get a diagnosis. Okay, this is not the back and forth. The moment you say you have breast cancer, how can we quickly get the patient into clinic? How can we get the patients into getting first surgery? And for a Medicaid population with equity and social determinants is such a big barrier. How did we do in LA General? So Dr. Ganai, can I invite you up? And Dr. Ganai is a surgical oncologist and is actually part of our COC, our cancer committee at LA General. Maybe we can go through the cancer navigation from the beginning.
Absolutely. It's a real privilege to be here. And yes, I'm a surgeon. I'm a surgical oncologist, so I'm the subspecialty trained surgeon. And I actually focus on GI and hepatobiliary cancer specifically. But I'm going to actually represent my team members as well, because surgical oncologists often start some of the initial phases of care for treating patients with solid tumors that are with curative intent. However, we are just part of a team that includes radiation oncologists, medical oncologists, geneticists, and in many GI cancers, nutrition consults, speech pathologists, et cetera. There are a lot of people that are integral for the proper care of the cancer patient. And we see that as the importance of multidisciplinary care. And that's something that we stress from the get-go. So in terms of the processes that are here, it really is involvement of the components relevant to the care of those cancers. I'll throw in my COC hat. I just came back from the Cancer Surgery Standards Program, which is through the American College of Surgeons and the Commission on Cancer. And one of the elements that we're trying to do is also ensure that cancer surgery is done appropriately with adequate endpoints, including node counts of various things that we know are linked with good outcomes. And part of the whole thing of developing standards, I think, is important because we do know that there are disparities that exist that actually can be even linked to the provider you go to, whether you are you can see gender discordant outcomes and racial and ethnic discordant outcomes in the provider. And we actually want to make sure that all patients are getting the same standards of care, whether they're an incarcerated individual or they're able to attend our regular clinics. Part of, I think, the efforts that we've started in terms of recently in terms of trying to improve our GI oncology care is making sure that we are delivering the same care, whichever surgeon sees the patient, and then actually making sure that the coordination of care is simplified in terms of processes. And so for cancers like gastric cancer and pancreas cancer, we are following our national guidelines, but also where there is multiple options, like in pancreas cancer, all of our patients are actually going through neoadjuvant therapy and actually having a process for consideration of additional staging procedures like staging laparoscopy. In addition, staging laparoscopy was not in full practice here for gastric cancer. We are now introducing that as a standard because if you're able to properly stage the patient, you can give the appropriate care for the patient afterwards. So in terms of from a DHS-wide effort, we're actually coordinating with our partner surgical oncologists at other institutions, including Harvard and all of you, to then create pathways that we all can agree on, and we will all proceed to deliver appropriate care in a coordinated fashion, which will help in the future in terms of with ability to collect data and metrics in terms of how we're doing in benchmarking. So in terms of the patient navigation process, some of these pathways also, I think, will be what we've done, in terms of graphically depicting these pathways as like a one-page pathway, is then we now can help in terms of educate our navigators. And I hope that in the future we can do the same thing for patient education to simplify in terms of a general understanding so they know the timings, because it can be quite daunting. Why am I not going to have surgery in a month? No, we're going to do this process where we're actually going to plan for the 3 months of chemotherapy, for example, followed by surgery, and kind of a general understanding and graphic of what that might represent. So in terms of, So in terms of our CQIP data, you've seen this slide that kind of shows that our population is primarily Medicaid. I think one of the great examples in terms of where we are, because for breast oncology care, we actually do have a very high quality breast fellowship program where we're training our future in terms of how to do appropriate breast surgery. We also have a kind of a protocolized way that all patients are discussed for breast care in a multidisciplinary fashion. And so we actually have outcomes that are above the COC standard across the board. And you can see even in stage 4 patients are doing better than the national average, which I think is something that's highly commendable. But it's really the kind of, in that sense, making sure that there is appropriate use of surgery, radiation oncology, medical oncology services, as well as integrating with genetics and then deciding in that sense the appropriate therapies.
Yeah, I can go through the final end. Thanks, Dr.
Thank you.
Okay. Thanks so much, Dr. Ganai. I'm just gonna, we do have our social work supervisor. I'm just gonna go through a slide for the cancer navigation, but I'm gonna just back up in the slide and how do I back up slide here? This is incredible. If you haven't seen, okay. I mean, as I think as clinician, we just present data, but this is unbelievable. I just told you we have a huge Medicaid population. I just saw this actually last week, so and it shocked me because, again, all COCs are one mainly private, right? And if you average that, look at stage 0 to 4, breast cancer, we have a better survival at LA General, okay? With a predominantly sicker population with all the healthcare disparities, and we're doing great, okay? So I just want, okay. And I don't think it's by accident. So I think there's components of this team. And I'm glad that we have leaders like Dr. Ganai and others who are, it's really shocking to me that in the cancer lines, there's no clear pathway that's understandable for patients. So if you get breast cancer, you're saying, okay, 2 weeks, 3 months, or 2 months, 3 months, like a really clear pathway. This is something that I think the clinical teams are really trying to reconcile. And I think it'd be incredibly patient-centered, if it could be translated and given to patients. So they're working on that. And I think that's a really great thing, but this is remarkable, and that's right next door. So anyone who wants to study it, our doors are open. Okay, so for the cancer navigation team, as you know, you only survive if you get to clinic, if you get diagnosed, and you have surgery, chemotherapy, and things like that. And the cancer navigation team, it is growing through the different lines. We have 10. These are, as you can see, head of our cancer navigators, Melissa Ramos. The Ramos is over there. She says hi. So her team, these are the most sophisticated cancer navigators, I would just say, in the LA County environment. So these are mirrored at all facilities, but they don't just learn to give transportation. They know that each patient that's impaneled has a primary care physician, has an integrated behavioral health. They don't do everything. They know how to direct patients to the resources they have. Because the healthcare, product is very complicated. But what they soon find out is, wow, if I'm with LA Care has resources, right? If I have a primary care physician, they have a nurse, they have a social worker, they have all this world of resources. They just don't know how to use it. And the great thing about having integrated cancer navigators with primary care team within the DHS system, knowing all the healthcare products, they really open a whole new world. And then they're tackling very serious issues such as in food insecurity and also just readiness to tackle cancer. So we don't have times for those, but maybe you guys have questions, we're happy to answer those. So that's what they've been dealing with, and I think with great success. And these are just all the things that they do day in, day out that I think makes a huge difference for our cancer patients, apart from the screenings and the genetics and treatments. All these things are things that I said are the elephants in the room that we've never been able to really address. Now we have a system for it. Okay, so how do we build a cancer navigation program with equity from the ground up? You have to have a mission, and you have to have someone that's going to really be there day in, day out saying, you must think of equity, okay? It's not equality, equity. We must address it at every facet. So we have Erica Braxton, you heard her. Second is, you gotta just call it the way it is. It's social determinants is a huge beast, all right? It's close to 60-70% of the problem. So you have to address it, you have to define it, you have to screen for it. You can't just assume you know it. There's a science to it. And lastly, from our 3 award-winning programs, you got to screen, you got to diagnose, and at the end, you got to get them to treatment. So that is the introduction. I don't want to hog too much of the Q&A, so I'm just going to ask one question for the rest of the panel, and then I'm going to open up for the questions for the crowd. Okay? We have, let's see, 12 minutes. All right. So I guess the question I'm going to have is, I would say this is a program, much of what we are doing at the county and LA Journal, I think there's success. So my question to each one of you is, can you define your biggest challenge if you were to take this program to another facility? What would you tell them to your counterparts? So for your equity officer, for your chief of social work, primary care, I would just say urgent care leaders, and finally, your physician leadership from a cancer committee standpoint. So why don't we start with Erica Braxton?
Is this on? Okay, perfect. I think the biggest challenge, if we were to take it outside of DHS and LA General, would be getting the buy-in, right? I think people assume that because we have the tools and we're doing the screening that equity is happening, and that's not the case. Inclusion, like I said, is a practice. You have to be intentional about it. And I think even having people come to the table, having integrated interdisciplinary teams is essential with the shared mission. So I think what we have to do to keep this work going is to continue to tell stories like this, that this is success, that integrated interdisciplinary approaches with inclusion being intentional works. And so we do have to take the time, but once we take the time to set up the system, it mutually benefits not just us, but the patients and families we serve.
Question. I think that if it does work. It does work. It's a lot of hard work, as we know. We're called to do more and more with less. What I would tell another partner, social work director somewhere else, is we also have to elevate our voices with the providers. We are an integral member of the care team. And I think that that's been one of the biggest challenges. I know that there's good intention, but it's very fast-paced at times when we're working. And being able to be inclusive in thinking about how does social work help this patient at the very front end of the diagnosis process and throughout the continuum is a challenge. But if we also begin to think about it, we will get better success, in particular for that patient. Thank you.
I'm going to say 2 quick ones, Dr. Lee. Sorry, they're going to be very fast. The first one, I would say, and you asked about other systems and recreating this in other systems, I would say give the patients the best chance at getting to the care that they need. If I could really connect with other systems, I would integrate the ways in which we share information. It's just a huge burden, and it causes us to have to redo studies that are costly and not good for the patients. So that's one thing. Don't send them with their 2 little pieces of paper. Send them with everything that they need in order to get the best care. And the second thing I would say is create this village. I know at the Wellness Center we have a very unique opportunity to be able to support the hospital with some of these wraparound services like food insecurity resources, like housing insecurity resources, filling out information. Primary care gives out laptops to our patients. We're trying to figure out how to teach the patients how to use those laptops, really to bring that equity and so bridge some of those gaps. So if everybody could have some sort of wellness center in their health systems, I think it would be really incredible as well.
Yeah, from the primary care lens, I think as health systems and payers and the state start moving toward value-based care programs and models, that partnership at the highest of level is critical. So I think we're really lucky at DHS that we have organization that does support a lot of that. So the work at the PCMH level is more the challenge, and I think if you know PCMH is a journey, and so different teams and the style and the disciplines that are there can be unique across the board and in different settings. And so really, how do you get those team members to work together in a coordinated fashion, under the lens of equity and aligned, is probably the biggest challenge in primary care, but it can be done.
Yeah, just to add to that, I think from the oncology perspective, the processes of navigation at a lot of other health systems are run by oncology nurse navigators. I think there's some benefits in terms of the social worker as being able to understand and address social determinants of health directly. And so those are just some things just to keep in mind in terms of that. And then certainly, every health system has differences in how data is collected and maintained and specific to the population, but yeah.
Okay, great. So why don't we open up for questions? Thanks so much for your responses. Do we have our first question?
Hello. So phenomenal work, and I'm so inspired. But I have two questions. One is, can we talk a little bit about the handoff? Like, if that makes sense. Like, okay, so I'm envisioning, the screening and the great work you guys are doing, and then there's the biopsies so that we understand, hey, what did we actually find on the screen? So your navigators that are in one component versus another, are they talking to each other? Do they huddle? And then, or is there just a referral process that you just put in an order and then getting to the OR to treatment as well? So that's the first question. Like, what does that sort of handoff look like between? But I mean, I hope you guys are proud because this is amazing. Yeah. But my second is lung cancer screening. Hello. Like, let's talk about it real quick. I am biased as a thoracic surgeon who cares for patients with lung cancer. But it's number one, we all know this, but I'm gonna have to say it again, killer, right? So we know that. Yeah. And we do so poorly in this state with lung cancer screening. So Dr. Kempa and team, so you have beautiful data, but can we get lung cancer screening on there as well? So thank you.
Yeah, let me answer those two questions.
Good questions. I'll deflect to Dr. Raff, who's our specialty director, to connect with you later. But yes, lung cancer screening is important. He's also a radiologist, so he can give you two perspectives. But no, absolutely. And we are working on lung cancer screening. Dr.
Campen, let me first just frame the question. So because that's a greedy question. First off, I think your question is about handoff and process, which is incredible. Those are generally the fallouts, right? Too many communicators, not the same message. And I think that's the strength of our cancer navigation program, is knowing all the players from the moment of the touch, from the screening, all the way to diagnosis and treatment. I can tell you, everyone is well-intentioned, but that well-intention actually creates a lot of stress for the patient, right? So a patient could be receiving something from primary care, from specialists, from radiologists, and it took us, Dr. Raff and many others, to basically get everyone in the room saying, okay, who's gonna contact the patient? Okay, who is the appropriate person to contact the patient, right? Because you don't want an appointment for a cancer clinic when you didn't even know the results, right? So that took a while for us just to map those pieces out from the patient-centered in, right? Because from a clinical healthcare system, it's efficient to just make everything electronic, right? Send a text. You got breast cancer. Sucks for you, right? Things like this. But we were very intentional in saying who should reach out, how should you reach out, how should it be scheduled, who's the one person responsible, then who activates the navigator, how should the navigators then be introduced. So the navigators don't get introduced until they meet with the clinician and they bring them into the team. So this is all from the team coming together saying, what would a patient want, right? So the handoff's incredibly important. I would say the workflow is that's another symposium. Every single surgeon, every single clinical team wants to do it in a particular way, well-intentioned, but for that reason, there's so much crosshairs and they want to just get the system out of the way, allow the patients to receive the information in an appropriate time. So I do think that's a big problem, and I think one of our successes is addressing that very point. Second thing, in terms of, I think, the success, it's shocking that it took us this long just to get this. And it's because we were so focused on spending money on emergency rooms and the inpatient. AM care was an afterthought, okay? And the fact that now you're getting an insurance and someone upstairs is actually saying, I'm giving you money, what am I getting back? That's value-based. And they set these targets saying, okay, we want those incentives to those patients doing breast cancer screening, colon screening. So we have an effective fiscal model to show that it can drive outcome. So I think this is what's going to drive value-based primary care and panel patients. And ideally, it should be for all cancers, right? All the research studies, all the COCs commission should provide the standards for the NCQAs to say incentives should be based on lung cancer screens and things. And that's where the monies will then go to teams like primary care and all the specialists to say, if you want money, this is how you're going to spend it because it's effective. So we've shown it in 2 different lines, and you can see the success. Let's do it for all cancer lines. So that's what I would say, but Dr. Camper probably has more details on that.
Good. Yeah, thanks, Dr. Lee. Yeah, no, just to follow up. Yeah, lung cancer screening is absolutely important. And then secondly, for primary care, a lot of the screening is happening. We're finding abnormal screenings. We're linking through our e-consult system, which is a whole panel of specialty clinics and specialists who can review the case and give us feedback. When patients do present with more advanced masses, et cetera, we can sync up with our urgent care, who we have a great partnership with, and they get kind of plugged into that process. But in primary care, often we're doing kind of the abnormal screen and referral, and then radiology and specialty care take it from there.
We also have turned not only the pre-tumor board, but we've also turned a lot to e-consult if it's nothing particularly urgent, if it's very time sensitive. We actually do real-time consulting in our urgent care. Dr. Lee's also been part of another effort, which is to actually place an order to specialty care. And then I think in the pre-tumor board, we're actually just having like very candid conversations where I can ask, like, who needs to see this person the quickest? Is it going to be, our thoracic interventionalist, or is it going to be our oncologist? And oncologists will be like, no, wait a minute, hold on, let them see them first. So we're really planning out those strategies in real time and with real conversations.
Thanks so much. Okay, do we have other questions?
We have one question.
One question? Okay.
We have a question from Mackay Freeman. The ability to get on an exam table easily, get accurately weighed is crucial for persons with physical disabilities. Care plus accessible access is key to addressing patients showing up. How have clinicians addressed accessibility and cultural humility toward individuals with disabilities whose needs are often overlooked? It's quite a...
That's a very deep question.
It is.
So, okay, I'm going to make one statement, but Dr. Campa knows this the best. I think one of the best things that having an impaneled population is that you have continuity. I think one of the biggest issues when we have individuals with disabilities or things, one visit is not going to do it. And the great thing in having a captive audience where patients have health insurance or impaneled in primary care, that visit, if you just had one physician one-on-one, is going to lack that type of assessment, right? That 15 minutes is not going to give you that type of refined assessment. What I've seen, and I'm going to have Dr. Camp kind of comment this more, is when you get a population assigned to you, and then it's their responsibility to do the screening, to say access is lacking, due to disabilities. Then they can leverage other part of the care team, social work, other healthcare partners to address that access. So it has to come with that entire team, and it comes from a very robust, what they call patient-centered medical home, PCMH. So Dr. Camper, you want to comment on that?
Yeah, and the other piece is just to comment more specifically, there are regulatory compliance requirements that actually come from the state, that the health plans align to, that the clinics are responsible to be in compliance with, that are ADA, that do need to have bariatric exam tables scaled, wheelchair scaled, et cetera. So the system is set up through the state, right, to ensure that the clinics are operating with enough resourcing to support all patients of all abilities. And then secondly, there are DHS requirements for us to do training, cultural humility, implicit bias. At LA General in the primary care setting, we've invested additional funding to do those trainings as well, empathic inquiry, all these things to really support, again, multiple people of different disciplines, of different educational levels and licensing backgrounds to have a same baseline level of how you approach patient care. And we've seen, again, that drives better outcomes for the way all of us interact with our patients.
Okay. Thanks so much. I want to thank, do we get one more question? Okay. Last question. Yes.
Hi, everyone. My name is Tia Delaney Stewart, and I lost my husband. It'll be 15 months on Sunday to a rare cancer, gastrointestinal stromal tumor. I represent the Council of Black Nurses, National Black Nursing Association, and even being a nurse and on that journey with him, and we had amazing insurance. If I wasn't able to navigate him through this journey, his journey would not have been dignified. There are many barriers that we faced, and I often had to say I was a nurse, and all the years of experience I had to bring to the table. And it was so unfortunate because I really don't like to do that. And I felt like I should not have had to have done that to allow my husband to have a dignified journey through this cancer. My question today is, I sit as a LA County Commissioner for the Hospital and Healthcare Delivery Systems for District 2 with Supervisor Mitchell, and I took that appointment because I see how the social determinants of health affect our community gravely, and especially in the area of getting a diagnosis and navigating the systems. I think what you guys have done and have demonstrated today is simply amazing, and I've had to keep myself together today because I just didn't want to be in tears, because I think it's beautiful, because I think it was intentional. And I think that's what's missing all the time in our healthcare delivery is intentionality. It is a lot of work. It's a lot of work to be intentional to serve those who need us the most. And you've done such a great job. And so my question to you is, because we'll be meeting with the hospital CEOs in a couple of months, and I really want to know what recommendations we could give to say, how they could work with you to get this across the board. Because being a nurse, people call me all the time and ask me about this. And I've had people say, I've been at the hospital and I have my paper T and they say I have a mass. And I'm like, well, what kind of mass, And then I start this process with them, but I'm just one person. But we need this in all of our facilities. We need this intentionality to serve the folks that need us the most. So one, you've done such a great job, but if there's any recommendations that you could give to me to bring back to the table to say how we could help support this program being implemented in other facilities, I'm open to any recommendations. Thank you, guys.
Thank you for that comment. I'm really touched. I have to say, again, I'm not an oncologist in cancer space. I'm actually an endocrinologist. And I'm here because there were individuals like yourself that advocated for the patients in the county. They said, this is not right. Patients' voices are muted. There's things they're dealing with. We're not paying for the things that's really going to affect, their cancer outcome. And it's because of them that we are actually at the table. We're fighting for the patients. We have patient advisory councils. We're listening to them all the time. But the difference is we're doing something about it. And so thank you for that. I would say that the thing that I would say for us is, I think it's been our mission to fight. Every time we get together, we're always telling our CEO, what works, what's not. I do think a success of a program like this, if there's any way to promote probably better partnerships we do these things, we show outcomes, but we want to make sure that the health plans or the board understand that investment is worth the investment. So if we had better partners to come and just showcase this more, we don't want it to be in our own echo chamber. We want to show that, hey, we're putting ourselves to the test. We're here to serve our patients. And if it's better, let's fund it. Let's do it. Let's bring others to do the same thing, because I'm sure they probably are looking for the same things. So I would, as much as we can, promote the social work, promote the equity officer, okay? Let's make sure everyone has a robust primary care support, because I would say most hospitals really focus on the acute ED inpatient. And the moment they're out, something happens, but to really support an outpatient preventative screening and treatment structure, that always needs support. So that's what I would say. Okay. Did you want to? Okay, all right, guys. Thank you so much. I'd like to say thank you. I just want to thank the panelists and, thank you guys for having us. And we're just right next door. If one of you wants to connect, I think we're happy to partner with anyone. And so thank you so much for inviting us.
And I just want to also thank the panel and Dr. Lee for sharing your expertise and the great success and impact that you've had. You really spoke my love language and the love language of many of us in the room about partnership and about really wanting to develop opportunities to understand ways that we can disseminate the great work that's being done at LA General and at USC Norris, at UCLA, and at City of Hope, as well as our FQAC partners, Universal Community Health Services and Ultimed. So that's the whole goal of this consortium. So I'm super excited that we're able to hear that as our last comment before we go on break, which is now time for a break. So we will break until, I think, 11:30. And then reconvene with our next panel discussion, which will continue this important dialogue. So thank you, everyone.